Just get my slides up here. Okay, well, I won't introduce myself again, other than to say I'm a cardiologist from Cardiff in the United Kingdom. I run a pulmonary embolism team there, which is multidisciplinary, and an absolutely essential component of safe PE practice is making sure you bring your friends in, because PE is a difficult disease. If you're relatively new to this space, there's no one specialty that really has all the knowledge and understanding to be able to treat every patient from start to finish. So it's a team sport. These are my disclosures, which include Boston Scientific. So I'll start with just a case vignette. So this is a 56-year-old lady who was immobile awaiting orthopedic surgery following an ankle injury, and she presents with sudden onset of breathlessness. Her only past medical history is hypertension, for which she's taking an ACE inhibitor, and importantly, a beta blocker. Now, if you see this sort of CT and you're used to treating pulmonary embolism patients, it should send a shiver down your spine, because when you see a grossly underfilled left ventricle like this and a grossly dilated 6.5 centimeter right ventricle, you know this patient's in trouble. So whatever somebody tells you down the phone about their apparent observations, whenever the LV is underfilled like this, I know this is a patient I'm going to have to take on. And I really think that underfilling of the left ventricle is the key aspect of CT selection, that you only really get the RV-LV ratios above 1.6 when you start to get underfilling of the left ventricle, and it's a really ominous sign. When you do a cardiac index on these patients invasively, you find that they are frequently in shock even if their blood pressure is maintained. And you can see that she's got a saddle embolism here. This is a photograph of the actual OBS chart that the lady gave me permission to use, and you can see that this concept of a cutoff of 90 millimeters of mercury demarcating the difference between massive PE, high-risk PE, and intermediate high risk is a little bit basic. And you can see how fluid this situation is. Her second observation was transiently 87 systolic, and then she responds to some fluids. You can see this oscillatory pattern that you frequently see in patients with left ventricular underfilling. And note how the heart rate at the bottom of the screen here is only 70 to 80. You'd be surprised how often people don't take into account beta blockers when they're ringing me and telling me about the status of their patient. Well, we're not worried because they're not tachycardic, even though they're on 5 milligrams of bisoprolol. So the risk profile of this patient is significant. Tachycardia, which is, in my view, the best sign of prediction of right ventricular impairment, was blunted by beta blockers. But when you take into account a multimodal assessment of this patient, their risk of death or hemodynamic collapse at 7 days is about 20%. So when you think about all those patients who are in intensive care and in coronary care, if you take someone who's just had an ST elevation MI for myocardial infarction, has had a primary PCI, the risk of that patient in coronary care is about 3%. And yet we've got these patients with pulmonary embolism and just a slightly low normal blood pressure and hypoxia, who may be somewhere in the hospital in some dark corner with a high flow mask, not getting that sort of observations, and yet this patient's risk is 20%. So how do we risk stratify them? Neil's briefly alluded to the ESC guidelines from 2019. Low risks, easy to understand. This is a patient without evidence of RV strain as described by CT or echo, and a patient without elevated cardiac troponin levels. These patients, 60% of pulmonary embolisms, they're fine. They can usually be managed on an ambulatory pathway given a DOAC and sent out. The high-risk patients are unstable. I think it's highly likely we're going to see an evolution of the description of this group to include other measures other than a blood pressure below 90, because it really is an end-stage finding, a blood pressure below 90 in pulmonary embolism, particularly in young patients. And I think we need to get a little bit more sophisticated as to how we describe patients at risk. And then the really exciting group from the point of view of developments over the last 10 years is the intermediate risk pulmonary embolism group. So intermediate high risk, this is the golden group. If you're not doing pulmonary embolism interventions, this is where you need to start. So this is a patient with clinical risk markers as described by a positive SPESI or a PESI class 3 to 5. So that's a patient with things like tachycardia, low normal blood pressure, hypoxia, and with a background of cardiorespiratory compromise, some of those features. And they also have RV dysfunction, either an elevated RV-LV ratio over 1 or elevated cardiac troponin levels. And in reality, if you're taking these patients on, their RV-LV ratios are typically much higher than 1. Intermediate low risk is where you have either troponin elevations or a RV dysfunction, and most of those can be managed conservatively. So that orange group, as we call it, that's about 15% of pulmonary embolisms. And those are the ones I think that new programs should be looking at. So when you look at the mortalities of these patients, so high-risk PE, it's only 5% of the PE population. They tend to front-load their mortality. At 3 months, it's 58% all-cause mortality, and PE-related mortality in that first 6 to 24 hours is about 40%. So these patients need reperfusion. There's not much discussion about that. The only discussion is the modality. And the problem with systemic thrombolysis is that 2/3 of patients in the ICOPA registry didn't get it because there's always a reason why people will hesitate. Not necessarily the right reason, but these tend to be elderly patients, comorbid, they may have cancers, they may have just had surgery, and so people are hesitant to give systemic lysis. But it does, on observational data, reduce mortality from 70% down to about 30 or 40%. So reperfusion therapy is very important there. Then you have intermediate risk PE, about 40% overall, but as I say, about 15 to 20% of them are this intermediate high-risk group, with a mortality that ranges from 3 to 20%. And that range just emphasizes the importance of risk stratification, understanding what their echo looks like, what their CT looks like, what their biomarkers are, what their background risk is. And then low-risk PE, we're not going to get involved in those as interventionists. So why can't we just give systemic lysis? So I still talk in rooms where people will hear cases like this and they'll say just systemically lyse them. And I think selectively that does remain in the guidelines, but this has been tested for intermediate high-risk pulmonary embolism, full dose lysis versus placebo on top of heparin, and it was patients with RV dysfunction and an abnormal troponin. The primary outcome was all-cause mortality and or hemodynamic collapse within 7 days, and it was a balanced outcome. So what happened was mortality was slightly lower with lysis, not significantly so, and then hemodynamic collapse was prevented. So this is no surprise to any of us. If you dissolve clot, you improve hemodynamics. The problem is the mechanism of doing it. So full-dose tenecteplase was associated with a significantly increased risk of major extracranial bleeding and of hemorrhagic stroke. So 1 in 50 patients had a hemorrhagic stroke, which when you're dealing with a 40-year-old lady is not good. So it was a mirror image. So what we want is to be able to preserve those benefits from hemodynamic collapse without causing those hemorrhagic strokes and those major bleeding complications, which if you're over the age of 75, it was 15 to 20%. And a lot of those patients are coming to hospitals now with pulmonary embolisms. So we've heard about EKOS. That's the primary reperfusion modality in Zurich. The nice thing about EKOS is it's easy. So any interventionist can do it. And in fact, there are places where electrophysiologists are doing it, interventional radiologists, vascular surgeons, anyone can put EKOS into the pulmonary arteries safely. And the skill set required is very easily learned. It's a catheter that runs lysis down the tubing itself, and the pulsing of ultrasound pulses droplets of alteplase directly into the clot. And that probably allows us to reduce doses. If you give enough lytic, you'll overwhelm clot. The question is whether you can reduce that dose using ultrasound, and Neil showed you some bench data to support that. The mechanism is ideally fibrin separation, and then it pulses the droplets up. So it's like the Bellagio fountain in Las Vegas. If you put the EKOS underwater and turn it on, it pulses the droplets about 12 inches out of the bowl. And the idea is that allows greater contact and greater surface area. It doesn't break the fibrin. If you gave enough ultrasound to break fibrin, you'd damage the lung. So its job is just to sort of shake it and create gaps in the middle to allow drug to get into the middle through this pulsing mechanism. This is the trial program. So Niels did Ultima and published it in 2014, a randomized trial. It was only 59 patients, but it was actually powered for improvements in RV outcomes. And it showed that at 24 hours, you had virtual normalization of the right ventricle with EKOS plus anticoagulation, whereas anticoagulation showed no change. And then Seattle 2 is a single-arm study that was using CT at 48 hours, 150 patients, just again confirming that this was a relatively safe intervention. There were more access site bleeds in that study, just emphasizing the importance of using ultrasound to get in and out of blood vessels, and that's been adopted now following that study. And then I was involved in Optimize in 2018, a dose-finding study. I'll show you some data on that in a minute. And I'll also show you some data from Knockout and talk about high python. So these are the outcomes from Ultima, reduction in RV-LV ratio and very good safety outcomes. And we see not very much difference with heparin, very little bleeding in that study. And what's interesting is out to 90 days, you see that persistent benefit in right ventricular function, that these patients who are treated conservatively have a lag effect where their right ventricle is not truly normal. And when you do RV strain rate imaging on echo, we do see that. Seattle 2 Again, very good data, very good 30-day mortality data for a group with predicted mortalities. About a quarter of these were high-risk pulmonary embolisms, so-called massive pulmonary embolisms. There was no intracranial hemorrhage and a mortality at 30 days of 2.7% from a group with a predicted mortality rate of 15 to 20%. There was more bleeding than we would like in this study, mostly access site. So micropuncture under ultrasound has hopefully reduced that significantly. This is an interesting part from Seattle too, is they looked with CT scanning and they found that much of the reperfusion was happening in the periphery rather than in lobar segments where clot had been reduced on CT scanning. And so this raises this tantalizing question of what role will lysis have going forward whilst we have all these other modalities like thrombectomy? And will this peripheral reperfusion that's occurring at the same time with catheter-directed lysis provide other benefits over and above restoration of flow in proximal major vessels? And we need more work on this, more research. Optimize was a dose-finding study, so many of us had observed that these patients were getting better within 2 or 3 hours, and yet the infusions were running for 10, 15, 20 hours. And so it looked at 8 milligrams over 2 hours, 8 milligrams over 4 hours, 12 milligrams over 6 hours, and 24 milligrams over 6 hours. So this latter one was a much more rapid infusion of a larger protocol than had been done before. It was stopped early after a patient had an intracranial hemorrhage with a background of a platelet disorder. And it was stopped by the Data and Safety Committee because the other 3 arms were doing pretty well without the need for that high dose. And what we saw is that they all improved the RV-LV ratio at 48 hours, despite the fact that there was a difference in modified Miller score clot burden change. So it appears that small doses of lysis can restore RV function, and it's not purely a central clot-dependent phenomenon, and this speaks again, is this peripheral reperfusion thing important? And this is the change in RV-LV ratio, and you can see how all the cohort did pretty well, and the changes were persistent out to a year. And we've published the 1-year outcomes in circulation intervention showing very good long-term outcomes. 2% all-cause mortality at 1 year from a group with intermediate high-risk pulmonary embolism is pretty good. Knockout PE is a large registry, so 900 patients retrospective, 489 prospective. And I'll just talk about the prospective data just to show what people are doing now. So the mean dose of TPA used was 18 milligrams, which is the dose we're using in HI-PEITHO. And the mean infusion time is 10 hours with very low rates of hemorrhagic complications. In this prospective study where the patients were consented before they were enrolled in the study, and so we're hopeful we're not being too picky in this cohort, there were no intracerebral events in 489 patients. So I think compared to peripheral systemic lysis, I think those are very good rates. And we showed significant improvement in quality of life at 3 months and durable improvements in RV function. So I'll just close by mentioning HI-PEITHO. I'm involved in the running of this. The PIs are Stavros Konstantinidis and Ken Rosenfield. And it's a European and American study which finally gives us the outcomes data we need. I mean, it's no good us coming and telling everyone they have to start PE programs until we show that the patients do better afterwards. And it's going to be an adaptive study design, so 400 to 540 patients from 65 centers worldwide. And it's intermediate high-risk PE with enriched features, so we're picking patients with tachycardia, low normal blood pressure, hypoxia, to try and get those ones who are on the verge of sliding into shock and to show that we can turn their outcomes around. And the 7-day outcome is PE-related mortality or cardiorespiratory decompensation. And we've started recruiting to that. Recruitment is ahead of target, and we'll hopefully have that done in 2024. So back to our patient. This was a patient I randomized in the Optimize trial. So 8 milligrams of alteplase over 4 hours. They started with a PA pressure of 72. This is the echo at baseline, and then 4 hours in, for the cardiologist in the audience, we've got substantial improvement in LV filling, septal motion, RV long axis function, and radial function. And that's only 4 hours in. So I think it's likely we're going to show clinical benefits with this in studies to come. This is the PA pressure at 4 hours down to 42 millimeters of mercury, and it subsequently normalized the next day. A very good clinical response. She was off oxygen at 24 hours, having had a bed booked in intensive care. This was the CT as per protocol of 48 hours. It's a research protocol. And again, you can see substantial improvements there. So I think there's no question this technology works. It works in a lot of people. The only question, I guess, is who you select and whether there's net clinical benefit, and that's what HI-PEITHO is all about. So in summary, intermediate high-risk pulmonary embolism is the golden group. If you're not doing pulmonary embolism, that's the group to start with. It's about 15% of all PEs, so that's about, you're going to be looking at candidates of about 150 candidates per million population. So if your hospital treats a patch of 1 million people, you're going to have about 150 cases to get your teeth into. Outcomes in this group are currently suboptimal. I think having a patient come to hospital with a preserved blood pressure and then have a mortality at 30 days of 20% is completely unacceptable. I mean, there's no question we need new treatments in this area. And the things to look out for are tachycardia, low normal blood pressure, hypoxia. Ultrasound-assisted catheter lysis, it's very simple. Anyone can do it. And we have RCT data for RV offloading and registry data showing good safety, but we need outcomes. And Boston have invested in this space now, and we've got a very large study enrolling that are hopefully going to change this space forever. I think the standard of care for this group will hopefully shift to some sort of intervention over and above anticoagulation, and mortalities of 20%. We can beat those, I think. Thanks very much.